This is Philippe Bilenga, and I will be illustrating the use of augmented reality in spinal, dural, arteriovenous fistula surgery.
This is the case of a 67-year-old man suffering from progressive weakness in the legs. He consulted because he could not walk anymore since 48 hours. The MRI shows a hyperintensity in the spinal cord centered on D8, extending 3 levels up and down. Those are signs of venous congestion, and when we study the vascular sequences, we see that there are arterialized veins, and we identify a shunt in regard of D9 on the right side. An angiogram is performed that allows the confirmation of the dural fistula located at D9 on the right side. On the left side, we identified the departure of the Adamkiewicz artery. We leave coils at the D9 level on the right side to allow further identification. Neuronavigation planification tool is used to segment the vertebra and as well segment the veins and the Adamkiewicz artery from the MRI and the angiogram. Here we show the D9 level seen from the side. The green dot represents the dural fistula, the blue is the veins, and the red is the Adamkiewicz artery. The patient position has been registered using the spinous process of D78 and D9, as well as the transverse process projection on the left and right side at the level of D9. We now see the projection of the vertebra in augmented reality when the microscope is aiming at the lower aspect of the pedicle. The vascular anatomy is studied prior to the skin incision by projecting vascular sequences of the MRI. The right lamina of the D9 vertebra is now exposed, and the aspiration is palpating the transfer process of D9. We now superimpose the augmented reality. We verify the correct accuracy of the navigation by checking the realignment of what is projected with what we can palpate with the instruments. The lamina of D9 has been drilled and the dura is exposed, and we can see just medial to the pedicle venous pouch adherent to the dura. The vascular structure of the dural fistula and the Adamkiewicz artery are projected in the augmented reality, and we see that it's quite well adjusting with the vascular pouch, and we can identify with a green dot the place where we believe we're going to find the dural fistula. A Doppler will now be applied on the dural fistula point and later on the radicular artery and on the veins. 8 milligrams of indocyanine green are injected intravenously. It shows the early enhancement of the dural fistula concomitant to the radicular artery and the delayed enhancement of the venous tortuous vessels. A Liga clip is applied proximally and distally on the dural fistula, which is later cut and coagulated. The Doppler is then used again to assess the flow in the different vessels, and we observe here very little flow. Here we're exploring again the proximal clip and the proximal aspect of the dural fistula, where we coagulate the vessel very close to the dura to be sure. There will be no bleeding. 8 milligrams of indocyanine green are injected again to demonstrate the slower flow, and what you can see here is that the snow is almost stagnant. The enhancement comes very late.
An intraoperative angiogram is performed that shows the occlusion of the dural fistula on the right side and the persistence of the Adamkiewicz artery on the left side. The patient recovers progressively and walks at 3 months. An MRI is then performed that shows the resolution of the medullary edema and the absence of abnormal veins. There are some artifacts associated to the Liga clips that are shown at the level D9.